Thank you so much for being on the webinar series today, provided by TAP, the Institute on Disability and Human Development, and LEND. And we're very excited to have Dr. Fedra Najjar here with us today. I will be turning it over to her to share information about her presentation.
Hi, thank you for having me. And my presentation today is going to focus on psychopharmacology of autism spectrum disorder. I do run the psychopharmacology clinic at UIC at the Institute of Juvenile Research. So today I'm going to cover very briefly the criteria for autism spectrum disorder, as everybody's familiar with those criteria. I am going to go over the problem symptoms associated with autism spectrum disorder because those are the symptoms that we try to treat with medications. Comment on comorbid diagnoses, and then I'm going to spend the most time talking about psychopharmacology of autism, including mechanisms and medications. So as everybody knows, the DSM-5 combined the criteria for autism in two criteria. And criteria A is persistent deficits in social communication and social interaction across multiple contexts, currently or by history. And criteria B is the restricted repetitive patterns of behavior, interests, or activities, again, currently or by history. So just to elaborate a little bit, the criteria A is the deficits in social emotional reciprocity, nonverbal communicative behaviors used for social interaction, deficits in developing, maintaining, and understanding relationships. And criteria B is the stereotyped or repetitive motor movements, use of objects or speech. I think everybody's familiar with that. It's those, like the hand flapping or like being interested in a part of an object, like the wheel of a car, where they do it over and over, or repetitive speech. The insistence on sameness, which means inflexible adherence to routines or rituals. And usually those routine and rituals are non-functional for patients with autism, but they insist on doing them. Highly restricted fixated interest, abnormal in intensity or focus, hyper or hyporeactivity to sensory input, unusual interest in sensory aspects. So I just covered those briefly because most of the audience are familiar with the presentations of autism. So what do we, why do I cover these, and what do we do with medications? Medications are used to treat the symptoms when they affect the patient's functioning. But a lot of time patients with autism, when they come to treatment with medications, they really don't come for the core symptoms of autism. So criteria A and B, we're going to refer to them as core symptoms of autism. And what they really come for is the problem symptoms associated with autism. Often patients with autism have certain behaviors and presentations that are extreme, and they affect their functioning and their ability to learn. So those are the symptoms that we like to treat with medications. And those symptoms are irritability. Irritability in autism describes the aggressive behaviors, like hitting, pushing, shoving, self-injurious behavior, like self-biting, scratching, headbanging. We're all familiar with tantrums that patients with autism present with. Some parents call them meltdowns. So those intense tantrums that last for a long time and they're very intense, that disrupt the social functioning of the patient or the family surrounding the patient or the school functioning or the work functioning. Anxiety is very common with autism, and it can be very severe and disruptive. Depression. Depression happens a lot with adolescents and young adults mostly. I see it a lot in college-age students. You know, it could even lead to suicidality sometimes in patients who make it to college. Compulsive behaviors, sleep problems. Of course, we're all familiar with how sleep problems are very prominent in autism, trouble falling asleep or waking up very early or disrupted sleep at night. Hyperactivity is very common in early childhood, in children with autism mostly more than adult. I think, you know, things I hear about is the child is hyperactive in the classroom, they're disruptive, they can't sit still, they can't focus. Adult or adolescents and young adult pace a lot, that pacing that get in the way of their functioning. Sometimes it can be soothing, but so that's different. We're talking about more of problem behaviors that affect the functioning. So I mentioned these just because when we talk about medications, those are the target behaviors or symptoms. Autism doesn't exist by itself. Sometimes some individuals just have autism spectrum disorder by itself, but there are a lot of comorbidities, and there are studies that are being done to see how common those comorbidities are. So common comorbidities with ASD, autism spectrum disorder, are ADHD. In the past, we couldn't diagnose ADHD with ASD, but with DSM-5, we can diagnose both. Obsessive compulsive disorder is a very common comorbid disorder with ASD. Anxiety could be either an associated symptom of ASD, or it could be, when it's very intense, it could meet criteria for a separate disorder. So when I say comorbid, it means like two disorders at the same time. Major depressive disorder, bipolar disorder, and schizophrenia. So those are the most common comorbid disorders that occur with ASD and that need to be treated with medications. So when we talk about medications and ASD, I'd like talk a little bit about how do medications work. It is believed that most of central nervous system disorders are caused by imbalances in neurotransmitters, and autism spectrum disorder is a central nervous system disorder. It is a neurodevelopmental disorder. So neuro means the nervous system, which is the brain. And the brain consists of, we have the organ of the brain, but there are brain cells. And brain cells are, they talk to each other. And, so the way they talk to each other is by neurotransmitters. So neurotransmitters are substances that are released from one brain cell to another, and they have certain functioning. And the way the medications work, they affect those neurotransmitters or the receptors. So for the sake of explanation, I'm using this slide that explains a little bit. It's a dopamine neurotransmitter, and I'm gonna go over neurotransmitter, the slide after this one. So this is a brain cell, and this is another brain cell. And in between, there is this distance, there is the space. We call it the synaptic cleft or synaptic space. So the neurotransmitters are formed in these vesicles, and then they travel, and then they get released. They get released in a quantity here, and they latch on to their specific receptors in the next cell. And then once they connect, they give a signal. So this is the dopamine one. With the serotonin, which I don't have a slide for, but I can tell you that with the serotonin, we also have receptors on what we call this the presynaptic cell. The starting one, they have receptors here, and sometimes when it's released, it attaches here and it goes back. So this is just to give you an idea how how the neurotransmitters work. And then when medications come, they could take the place of the neuroreceptor here, the neurotransmitter. They could attach, and then this goes back in the synaptic cleft, and then you have more dopamine in the synaptic cleft, right? So I don't want to complicate matters much, but I think this is important just to give you an idea how medications work. So they could work on blocking those receptors. They could work on blocking the receptors before, and then, affecting how many neurotransmitter vesicles they have in the cleft here. So I'm going to move on to another slides, and then if you have questions later, we can go back. But the neurotransmitters systems we have in the brain that are, that affect autism, we know the first one is the serotonin system, right? We know that there is hyperserotonemia, which means there are a lot of serotonin in the blood of patients with autism. This has been found in studies. The other system is the gamma aminobutyric acid receptor system, the dopamine system, the norepinephrine system, and other systems, but those are the more common systems implicated in autism. So this is just some background in terms of how, so we have to know, and we really don't know exactly, which one and what's the exact mechanism and what happens, but we have ideas and we have certain findings. So in order to develop medications to treat autism, we need to understand those systems. So over the years, the field have tried to develop medications to treat the core symptoms of autism, the ones I mentioned, the criteria A and B. And so some medications that have been studied are fenfluramine. If people have been around for a while, they've heard of naltrexone, secretin, oxytocin, memantine, and arbaclofen. And since those don't have specific indications now for autism, and they're used, but not, the results are not solid in terms of their effectiveness. So I'll just mention them at this point, and then if you have questions, we could ask them later and talk if we still had time. I mentioned oxytocin because it's been studied a lot. It's people have heard about it. It's the hormone that we're hoping that it helps with social behavior and social cognition. That's very important for autism. But so far, the studies have been negative in terms of double-blind placebo-controlled trials that have been used to see if oxytocin can help with the social communication in autism spectrum disorder. The most recent study has been negative. Now, is it available? Yes. Is it being used? Yes, in individual cases. But we don't know, how well it's going to work for the majority. So it is synthesized in the brain. It is circulated in the nervous system. We know there is some evidence that it is a little bit deficient in patients with autism, but the studies have not shown its full effectiveness. So how do we treat? Actually, in terms of those specific medications, so there are, as I mentioned, there are cases that have improved on certain medications that I've already mentioned, but the studies are open label. But in order to get approval for medications, it should work in double-blind placebo-controlled trials, but those medications have not shown improvements in double-blind placebo-controlled trials yet. It doesn't mean that they're not going to work, but maybe we need more studies. So you will see it used for individual cases. And, there are no FDA-approved medications for the social and language communication deficits in ASD and the core symptoms, but that it just means that the trials have not been done. So we need more trials, we need more studies. So the typical target symptoms that we target with medications, I mentioned it earlier, I repeated a little bit here just so we could remember them. So a patient who has severe aggression, a patient who has extreme self-injurious behaviors, like I have patients who have given themselves black eyes. I've had patients who have, like, their eyes are shut. Patients who spend an hour or two having tantrums at school, or when the parents are taking them, in the community. So those big tantrums we want to treat, the anxiety, the depression. So I mentioned these. Sorry if the slide is redundant. And again, with every symptom presentation, before considering medications, we need to assess, is there anything we could do behaviorally? We know that patients with autism are routine-oriented and have fixations. Have there been any change in their environment that's causing the aggression? Has there been any change in their environment that's causing the irritability? Another thing I like to mention also, before going to medications to treat those problem symptoms, have the patients with autism had any medical condition? Often I've seen patients, head banging because they've had a sinus infection. Patients have been irritable because they've had ear infections and they haven't been able to communicate. So before jumping to medications, we need to see what's going on. What else can we do with the routine and rituals, and what could we do behaviorally? So I'm not going to talk much about behavioral interventions, because this is not the focus of this presentation. I just want to say psychopharmacology is an adjunct to those primary interventions, and they're really used to help the patient benefit from their behavioral interventions, so we get them calmer. So first of all, we need to identify the target symptoms that are causing the significant difficulties, and the symptoms that we expect that will respond to medications, because as we know that some behaviors don't respond to medications. So the first concept of psychopharmacology is to identify the target symptom. And after we identify the symptom, everybody has to see it and agree, everybody involved in the patient care. So the second concept is to assess risk and benefit ratio. Is the medicine going to benefit the patient more than giving them side effects? So we have to assess that. And we have to also see, what do we expect from the medications? Because we know that patients with autism, they are going to have some behavioral difficulties. So what do we expect that will respond to medication? So it is a process. It's a process that will involve the patient, the family involved with the patient, the teachers, if they're going to school, the work, the day program, the group home, whoever is involved in the patient care, have all come together and understand what's going on. So it is important that everyone involved in the individual's care, and even the individual themselves, is possible, if they're higher functioning and they're able to report on the symptoms, to have a very clear idea of what the target symptom is, need to note that target symptom, and assess if it's better or worse, and then come together. So how do we determine response? Subjective feedback from all involved so I'm sorry, I'm repeating myself here. And so including the person who has ASD when possible. Behavior counts. I'm sure most of the audience are familiar with behavior counts in schools and group homes and day program. Scales. Before starting any medications, I usually ask people to complete the Aberrant Behavior Checklist community version. Some of you may be familiar with this scale. It is a scale of that has 58 queries about common difficulties encountered with individuals with developmental disorders. Each item is rated from 0, not a problem at all, to 3. The problem is very severe in degree. It is specifically developed to assess the effects of treatment. So we would like to do it at baseline before we start any medications, and then periodically after. It's completed by the subject's caretaker, and then and teachers. I said or teachers, I should say and teachers. So we need sometimes 2 at home and at the day program or school. And this scale is shown to be sensitive to drug effects. It says community version because when it was developed originally, it was developed for people who lived in institutions, residential, and it was developed for individuals who have intellectual disabilities, and then it was modified for individuals who have autism. So community version because now we have a lot of individuals who live in community. They're not all in institutions. So we like to, so it covers, so once it's 58 queries, and then the caretaker or the teacher completes them, like I said, on a scale of 0 to 3. And then there is a scoring sheet. And that scoring sheet, when we translate the or transcribe the numbers into the scoring sheet, it goes under 5 subscales. The irritability, it's called irritability, but when we read the questions, there are a lot of questions about anxiety. The subscale that says lethargy, it mostly covers social interactions. There is subscale for stereotypies, hyperactivity, and inappropriate speech. I find the scale very helpful. So once we get a baseline and we add up the numbers, and then we start the medications, and in a month, I would like the scales to be completed again and to see what happened to those numbers. So these are just before starting any medications. I'm sorry about the noise. Before starting any medications, we would like to cover all of those bases. Medications are important aspect of treatment, but of course they have side effects. And patients or families who have not tried medications, I find, are often very nervous about trying their children on medications. They worry about what's going to happen, and like how is the medication going to affect the brain? How are they going to deal with side effects? So those are all things that we need to have in mind before starting medications. Families need to be prepared. They need to be given data. And unfortunately, we have some data, but we don't have a lot of data like, other fields in psychiatry or other disorders in psychiatry. So it takes a lot of discussion with families, and it might take many sessions and many discussions with the family. And you guys can, care providers, whether behaviorists or teachers or therapists, can help a lot in this process in terms of, to help the family get to the point of accepting medications if they need it, and knowing that they've tried everything. So the classes of psychotropics that we use with autism are, the first class is the class of antidepressant. They're also anti-anxiety, and some of you have heard the word SSRI, which is Serotonin Selective Reuptake Inhibitor. And this class of, this is one class of medications. The other class is the antipsychotics, or we call them dopamine blocking agents. I'm hoping that the field will change the name of antipsychotics because they're not always used for psychosis. So this is another thing that I like to explain to families, that it's not for psychosis. It's just a medicine that could help with other aspects of behaviors and psychiatric symptoms. And the way they work is by blocking dopamine. Stimulants, alpha-2 agonists, and anticonvulsants. So I'll go over those medications in next slides. So I liked, so the SSRIs are medications maybe you've heard about, and I think I covered it in next slides. But the reason I'm going to the, so I'll go with symptoms and then what medications we treat, we use for those symptoms. And I started with irritability, aggression, tantrums, self-injurious behaviors, because we actually do have medications that have been FDA approved for the treatment of those symptoms in patients with autism spectrum disorder. So, and the reason we have FDA approval, because the studies have been done. And risperidone, probably people have heard about it, is one of the dopamine antagonists. Risperidone has been approved for the treatment of aggression, tantrums, self-injurious behaviors. And it is actually approved for age 5 and up. So I would reassure families that I wouldn't be worried about this, because we know that studies have been done. We know that in at least two double-blind placebo-controlled trials, risperidone have shown improvement in those symptoms that I mentioned here based on the ABC, the Aberrant Behavior Checklist. The other medication is aripiprazole, which is the trade name for aripiprazole is Abilify. This one also is approved for age 6 and up. So the FDA approval just means that they've had that the field has completed 2 studies that have shown the improvement. So the class of antipsychotics, so other medications in the same class and that have been used in treating ASD for the symptoms I mentioned are, so other than risperidone and Abilify, we have a medicine called olanzapine, and the trade name is Zyprexa, ziprasidone with the trade name Geodon, quetiapine, the trade name is Seroquel, paliperidone, the trade name is Invega. Haldol or haloperidol is one of the old medications. So before we got risperidone, aripiprazole, olanzapine, ziprasidone, quetiapine, paliperidone, all we had was haloperidol. And haloperidol was used to treat aggression in patients with ASD and was helpful. But you may or may not know that Haldol has long-term side effects that we don't like to see people have, like the rigidity, like looking Parkinsonian, or the drooling. But when we didn't have other agent, it was used for aggression, was helpful. Clozapine or Clozaril has also been used for autism, and clozapine is an antipsychotic that's proven to be more effective than all other antipsychotic. It's more effective, but when clozapine is used, it's hard to use. It needs weekly blood tests because it has a side effect that affects the blood that could be lethal. So that's why you have to have it weekly. So if the side effects happen, you can catch it early and then you could stop the medication or treat. But it has been used. There is another medicine that's not on the list, and I don't know if people have heard about it. It's like paliperidone. It's called iloperidone or Fanapt. So those medications have been used, and there may be others, but those are the most common. And some studies have been done, but in open label, or it's been clinical experience. But those medications, as we talked about, have side effects. The second concept, we want to be sure that it's worth trying those medications. So what are side effects that we could look for? So let's say one of the individual you're working with has the irritability, tantrum, aggression. They went to the psychiatrist. You completed the ABC. We thought that risperidone or one of the other medications, is worth trying, we try them, what to look for. So most of those medications can cause weight gain, and weight gain has its own complication in terms of health. And the medications vary in how much they cause weight gain. Unfortunately, the two that have been approved cause significant weight gain. You could expect to see sedation when a student is in school, might be sedated. So you have to see if those are changes after the medications were tried, are being tried. One side effects that I like people to be aware of that it would require immediate intervention is called dystonia. And dystonia means muscle tension. And that muscle tension, it could be side effects. Mostly side effect of Haldol, less likely to be side effect of the other dopamine agonists that I talked about. But it can happen. It can happen, and I have seen it. So that muscle tension, it could be in the neck. So if you notice that the patient is unable to move their neck, or they're complaining of severe neck pain and it's hard to move, so this could be side effect of the medicine. Another side effect that people may not notice or think it is muscle tension of the eyes, eye muscles. So eye muscles can get tense, and the individual could complain of eye pain or could have trouble moving their gaze. So often they look up and they have trouble moving their gaze down. And if they are on one of those antipsychotics, so I would immediately notice that and let the doctors know, because there are things that we could do with the medications to help alleviate the side effects. When patients are on those medications long time, they can have other abnormal motor movements and that are involuntary. And that we want to be careful, because autism by itself has some involuntary movements. I don't know if I want to call them involuntary, but they are motor movements like the hand flapping or the finger flickering or other movements that patients do, or tics. So we want to be sure that the movement we're seeing are different, are new on the medications, and if they're happening, to make note of them. Tardive dyskinesia, which are involuntary movements of the tongue or face or arms or even the trunk. And these can happen after long-term use of medications. It's very rare that you see it within a month or two. It's usually when patients have been on this medicine for months or years. Extremely rare, but very serious, what we call neuroleptic malignant syndrome, which is usually an emergency. It's very rare. I've used antipsychotics a lot. I've been practicing for 20 years, and I've never seen neuroleptic malignant syndrome, but I know it's something that could happen, and it's usually fever, sweating. The patients might turn red, and they may have like blood pressure changes. So this is an emergency where patients have to stop medications, go to the emergency room, and the treatment is usually what we call supportive. So they give them hydration, they manage their pressure, and they stop the antipsychotics. So we have to be aware of the side effects, but I don't want people to be scared of them. And again, we go back to risk and benefit. We have to think of the medicine. How are the benefits? Do the benefits outweigh the risk? So if they outweigh the risk, definitely we want to use the medications, because it's going to improve the individual's lives. So just to mention the antipsychotics and weight gain, some people can develop diabetes or hypercholesterolemia, and it can cause other social problems. We know that individuals with autism could be compulsive eaters. Some people eat compulsively. Now, whether that's due to the medications or not, we have to understand that. But these are problems that we need to be aware of and make note of and communicate to the psychiatrist And it can bring up issues over food because those medications can increase appetite. So patients are going to want to eat more. And there are, interventions that we could use. So for the symptoms, target symptoms of anxiety, depression, insistence on sameness, trouble with transitioning. So for those, we use mostly SSRIs, the serotonin selective reuptake inhibitors. And we talked about how, they can work in the brain. And the other one is clomipramine. Clomipramine is a very old medication, and it's been used for obsessive compulsive disorder. It has side effects like cardiac side effects. It's not first line. We don't use it much anymore, but in cases of severe OCD, I've had parents who brought it up to my attention, so that's why I mentioned it there. Maybe some people have not heard about it, but just in case you've heard about it, it's there, it's still in the market, and it still can be used, but it's not the first line. First line is serotonin reuptake inhibitors. So the SSRIs you probably heard about are fluoxetine or Prozac, fluvoxamine or Luvox, escitalopram or Lexapro, citalopram or Celexa, sertraline or Zoloft, buspirone. So buspirone is it's a little bit different. It works on serotonin, and it's mostly for anxiety, not so much for depression. But we know that Prozac there've been studies in autism with Prozac, with Luvox, with Lexapro, Celexa. And sertraline, has been studied for anxiety, but definitely the first four have been studied. There've been major studies, big studies with those medications showing improvement in anxiety. So what are the side effects of those SSRIs? Of course, there are no medications without side effects. They're usually very well tolerated when dosed correctly. Usually we like to start with small dose because if the dose is too high, they can cause side effects like irritability, disinhibition. Some people get more activated. They can have sleep problems, trouble falling asleep at night. They could become silly, excessively silly, and we call something called mixed state. It's almost like manic state if they're dosed very high. And of course, that can happen with people who have predisposition to have mania. So like patients who have family history of mania, let's say. But if dosed high, you could see those side effects. So it's important to make note of those. And if you notice them, to inform the parents or the doctors. So other medications, antidepressants that have been used are bupropion or Wellbutrin, mirtazapine or Remeron. Remeron is highly sedating, so it's a medicine that can be helpful with patients who have trouble sleeping. They take it at night, it helps with sleep. Duloxetine or Cymbalta, it's also medications that can help with pain in addition to depression. With high functioning patients with autism who present with pain and depression and who are like stuck on things, I found duloxetine to be helpful. Those medications are used for patients who couldn't tolerate SSRIs, so patients who have developed the side effects to the SSRI mentioned before. But in general, it's better to use SSRI as a first choice because we have more studies of SSRIs with autism. In terms of the symptoms of hyperactivity, impulsivity, and attention, that we see mostly in children and latency age who are in school, unable to sit still and learn, or unable to engage in ABA treatment, let's say, because they're so hyper. So we use stimulants, and the stimulants are like the methylphenidate is one family, and under this family we have the Ritalin that you guys have heard about, Concerta, and Focalin. So all those three medications are methylphenidate or stimulants. And the amphetamines like Adderall and Vyvanse. We know methylphenidates have been well studied in autism. There was the big study, the research unit on pediatric psychopharmacology. One of them is, they studied Ritalin in this population. And it's interesting, with the younger children, what I found that sometimes they're even sensitive to stimulant. They take them and they can't tolerate them. They become more activated or more silly or anxious, and those are some side effects. So there is a small subpopulation of autism spectrum disorder children who cannot tolerate the stimulants. So what do we do when they have this extreme hyperactivity and impulsivity? Especially, and I see hyperactivity, impulsivity, not just in the classroom. Sometimes patients, like, they're walking with their family and then they just run away from them and they cross the street and it's dangerous. Or some people run out of school and that, of course, that could have many reasons behind it. But if it's just impulsivity, so it's dangerous and needs to be treated. And of course, the stimulants are first-line treatment for those behaviors, but if patients cannot tolerate them, then we have other medications like Strattera, which another name for Strattera is atomoxetine. And atomoxetine is approved for ADHD and the typical neurotypical patients or ADHD in general. So Strattera could be used, or guanfacine, and other names for guanfacine are Tenex, or the long-acting guanfacine is named Intuniv. Clonidine is immediate release, and Cabfay is the long-acting clonidine. Those medications can also be used for hyperactivity, impulsivity. Clonidine definitely could be used for aggression, and it has other indications as well that I'll get to. What are the stimulant side effects? So the main side effects for stimulants, I mentioned the methylphenidate like Ritalin, Focalin, Adderall. Those could decrease appetite. So anorexia could be a side effect. So you give them the medicine, they won't eat. And the anorexia is a transient side effects, meaning the medication stays in the system for so many hours. So like methylphenidate, the immediate release can work for 4 hours, the extended release for 10 hours. So for that period of time, patients may lose their appetite, but then the appetite could come back when the medication wears off. The other side effect is trouble sleeping. And the trouble sleeping with stimulants is just about the sleep onset. So if somebody's bedtime is at 9 o'clock, let's say, and you give them stimulant during the day, they may not be able to fall asleep at 9, but they may be able to fall asleep at 10 or 11. So it can push the bedtime, but they should be able to fall asleep and then stay asleep if this was their baseline. So those are things we need to be aware of. And we have to do something about it. So if the patient is benefiting from the stimulants, they're able to sit down and focus and benefit from ABA treatment and be able to focus on schoolwork and learn skills and social skills, then we need to keep the stimulants. But there are ways we could deal with those side effects. For example, you could give the patient meal before they take the medicine. So give them a big breakfast and then give them the medications. Once their appetite comes back, don't be too rigid about the dinner time. You have families who are very rigid, like, you have to eat at 5, and then after that, you can't eat. No, you eat whenever you're hungry. So if patients gets their appetite back at 7 or 8, just let them eat their dinner then. So those are things we could, work around the side effects of the medications. One major side effect is rebound. So sometimes once the patient is able to focus and calm down during the day with their hyperactivity and impulsivity, once the medicine wears off, they become hyper again or even more hyper. But I have families say, okay, they want to run, I'll let them run in the basement. They hyper just like they could, be hyper. So aggression and tantrum. So sometimes we say, well, it's good to know what's the reason behind the aggression and the tantrum. So if it is anxiety, if it's routine, then use an SSRI. If it's impulsivity or severe aggression, then use antipsychotic like risperidone and aripiprazole. So sometimes it's really always important to know what's behind the symptoms and what could we do before. But what's, I mean, I find this very, very important because in this population, and even in younger children who don't have ASD, sometimes their aggression is a presentation of an anxiety, not so much impulsive. So, if you break a routine, then they become aggressive because that's their way of communicating. So if it is anxiety, we use serotonin, SSRI, and if it's impulsive aggression, we use aripiprazole or risperidone. So anticonvulsants are also used for aggression, and it's like Depakote, if people have heard of it, carbamazepine, which is Tegretol, lamotrigine or Lamictal, oxcarbazepine or Trileptal, lithium, which is category by itself. So it's a salt, but it's a salt by chemical substance, but it's used it's not an anticonvulsant, but can be used for aggression and mood changes. Of course, they have their own side effects. Sleep is a major symptom in ASD, and melatonin. Melatonin is the most studied medications for ASD. It's safe. It's used. Better to use it in small doses than in high doses. Some people think, if my child can sleep, I'll give him a higher dose. No. Clonidine is another medicine that is used for sleep onset, and it's very helpful. So in summary, medications are commonly used. We have to identify the target symptoms of autism, associated symptoms. We have to focus on connecting the medications to the symptoms and get measurements and scale to track improvement and change or lack of, making sure we can recognize the side effects and monitor the progress. So thank you all for listening to this webinar, and thank you for working with individuals with ASD. And I'm going to end here, and if we have any questions, I'm happy to take questions.
Wonderful. Thank you so much for your presentation and that just wealth of information. We have a few questions. And the first question is from someone who says their 23-year-old son aged out of the school system. They're on a waiting list for an adult day program. So he's been home with mom 24/7 for 6 months. Now he's refusing to leave the house, to the point of even getting violent if mom insists. Do you have any idea of what's going on? And they provided some information about the daily dosage. So this person is on 5 milligrams of risperidone, 75 milligrams of topiramate, 20 milligrams of propranolol, 30 milligrams of Lexapro, and 600 milligrams of Seroquel. I can show you on my computer here so you can kind of see the list and see if you have any insight to share.
Sure. So the hardest time is when patients stay home all this time, because we know how individuals with autism, they do well when they have structure, and routines. So now he's refusing to leave the house. Okay. So when people tell me they're refusing to leave the house, I think of anxiety. There is definitely major anxiety because of just getting used to stay. So I'd like to know more about what's behind this anxiety. What what has he been doing with his time at home. He's definitely on a lot of medications, and the Lexapro 30 milligram is, it should be targeting the anxiety as well as the propranolol, I imagine. I mean, medication-wise, I don't think there is room for any other medications here. And I don't know how he progressed to get to this list of medications, whether there were recent changes. But what I would say at this point, probably do gradual reintegration into the community in terms of leaving the home. That's what I would suggest.
Great, thank you. We have another question. That question is, can SSRI cause increased levels of AST, ALT?
Mm-hmm. Very unlikely. SSRIs are very safe, and they don't use, so AST and ALT as liver enzymes, and it's very, I haven't heard of anybody having those side effects on SSRI. There must be something else going on with the liver.
Thank you. Another question is, can SNRIs treat target symptoms of anxiety better than SSRIs, especially if SSRI is causing side effects of irritability and mixed state?
So, so when you say SNRI, so you have the serotonin, which the serotonin can target anxiety. Now, I'm not sure yet that we can say they treat it better than an SSRI, but it's definitely the second line if patients have had side effects on SSRIs. And, I think it should be tried, and it can be helpful. And in terms of better, I think that's very individualized. Each individual may react to medications differently. So I would say, if they can't tolerate SSRIs, it's good to go to SNRIs.
Great. And another question is also, how long can melatonin be taken, and what is considered a small dose?
Mm-hmm. A small dose could be either a 0.5 milligram or a 1 milligram. And, I know that there are on the market, we have the 1 milligram, the 3, the 5, and the 10. And the individual can take it as long as it's benefiting them and they're needing it. There are studies that show that if melatonin is taken early in the evening, like at 6 o'clock at a small dose, it can trigger the endogenous melatonin, which means that the melatonin that the brain produces, because all our brains produce melatonin at time of sleep, and that helps us sleep. But for some individual, they may need more. And it is thought that a small dose at 6 o'clock can trigger the brain to release more melatonin at bedtime and help with sleep.
Great, thank you. We had a comment that this was an excellent presentation, very informative and helpful, and happily it reinforced what we've been hearing from our son's primary prescribing physician, so that's great news. Another question is, would you mind elaborating on how convulsants would work to treat aggression or mood changes?
So they do, anticonvulsants are proven to target aggression, not just in ASD, in patients who have aggression who are neurotypical. So Depakote has proven to target the aggression. So sometimes some patients have predisposition to have mania. And mood changes could be part of mania. We talk about mood swings, and definitely bipolar disorder is comorbid with there are people with ASD who have bipolar disorder, and their aggression and mood changes is because of that comorbid disorder. And anticonvulsants are indicated for the treatment of those patients. Now, in terms of in terms of brain, in terms of how they affect the neurotransmitters in the brain, I don't think I mean, some of them work on the GABA receptor, and some of them work on other receptors in the brain, and it helps that way. So I hope I answered that question.
That's great. Thank you so much. I see we do have a few other questions, but we're coming to the end of our time. So I want to encourage you, if you have other questions, to feel free to email. And the email of Dr. Fedra Najjar is here on the slide, najjarf@uic.edu. I want to thank you again for your fabulous presentation and all of the great information that you shared. And I want to also let you all know that our next webinar will be happening on December 11th from 12 to 1 p.m. Central Time on understanding the pathological demand avoidance profile of autism spectrum disorder. Feel free to register at the link here to join that webinar. Thank you so much and have a good rest of your day. Take care.